Okay, so it's a simpler topic, diagnosing STEMI in patients with right-banded branch lock. And we all learn that left-banded branch lock is bad. It's associated with increased mortality. Well, right-banded branch lock is not so bad. We can identify ischemic changes with ECG. And right now we are changing. We learn that left-banded branch lock may not be associated with huge infarct and catastrophic events. Actually, it's not a sign of acute myocardial infarction by itself. And we are now focusing on the right-banded branch lock. So this is a paper by Widimsky from 2012 that started the business about 6,700 patients with acute myocardial infarction who underwent coronary angiography. Acute myocardial infarction, not STEMI. This is important. 427 of them, 6%, had right-banded branch lock. Half of them with ST segment elevation. TIMI flow 0 in the infarct-related artery was found in 52% of the patients with right-banded branch lock versus only 39% of the patients with left-banded branch lock and 57% in STEMI patients with narrow QRS. 22% in patients with ST depression, and they are bringing as a proof that right-banded branch lock by itself is associated with occluded infarct-related artery. TIMI flow 0 in the infarct-related artery was found in significantly more patients with new or presumed new right-banded branch lock than in the group with old right-banded branch lock. 3-vessel disease was found in 35% of the right-banded branch lock patients versus 30% in patients with STEMI and 53% in patients with ST depression. In-hospital mortality was 14% in patients with right-banded branch lock, 13% in left-banded branch lock, 5.4% in patients with STEMI, and 6.3% in patients with ST depression, claiming that right-banded branch lock by itself is associated with high risk. In-hospital mortality was higher among patients with new or presumably new right-banded branch lock than in patients with pre-existing right-banded branch lock. Another paper in 2016 by Chan, almost 12,000 patients with acute coronary syndrome, 5% had right-banded branch lock. RBBB on presentation. They don't specify if it's new or presumably new or old, was associated with older age, male sex, more pre-existing cardiovascular risk factor, higher GRACE risk score, and worse Killip collapse. Right-banded branch lock was significant independent predictor of in-hospital mortality, but not 6 months mortality. Angiography revealed that LAD disease, left main disease, 3-vessel disease were more common in patients with right-banded branch lock, and the associated with of right-banded branch lock with mortality was equal in patients with STEMI and non-STEMI. This study in American Journal of Cardiology from 2021 analyzed the outcome of patients with anterior STEMI with and without right-banded branch lock. So they retrospectively look on diagnosis of anterior STEMI, and 1.8% had right-banded branch lock. Patients with right-banded branch lock were older, had significant more comorbidity than patients without right-banded branch lock, and of course, mortality was higher, 15.3 versus 9.2. And so RBBB was associated with increased 30-day mortality, higher risk of heart failure, complete heart block, and need for pacemaker. However, they use ICD-9 codes rather than direct analysis of the electrocardiogram. So they could not separate between pre-existing versus new or presumably new right bundle branch lobe and between permanent or transient rate-dependent right bundle branch lobe. Based on the Widimsky study, the 2017 European Society of Cardiology guidelines said, patients with myocardial infarction and right bundle branch lobe have poor prognosis. It may be difficult to detect transmural ischemia in patients with chest pain and right bundle branch lobe. Therefore, a primary PCI strategy should be considered where persistent ischemic symptoms occur in the presence of right bundle branch lobe, which is actually a major change from previous what we believed. And actually, do we really have data to support it? I mean, we have data that overall they are associated with higher risk factors and maybe more occluded artery, but there is no direct evidence that reperfusion therapy, like in primary PCI, reduce anything in patient with right bundle branch lobe. So the right bundle branch receives its blood supply from the anterior septal branch of the LAD along with the AV nodal artery. A proximal LAD occlusion can result in a new right bundle branch block, which is often accompanied by left anterior fascicular block because they have the same blood supply essentially. Those types of intraventricular block, right bundle branch block with and without left anterior, are reversible with reperfusion therapy. And this is an example of a patient with anterior MI, S elevation in one, AVL, the anterior leads, and reciprocal ST depression in the inferior leads, with right bundle branch block, left anterior fascicular block. Transient right bundle branch block in inferior STEMI is rare. It can be explained by ischemia of the proximal His bundle, selectively inhibiting conduction to the right bundle branch lobe. As I said, the His bundle is supplied by the AV nodal branch and the first septal branch of the LAD. However, the right bundle branch lobe can be previously unknown. It can be rate dependent. Patient with MI may develop tachycardia. So it can be due to stretch of the right ventricle, etc. This is inferior MI with right bundle branch lobe, and we don't have anything, we don't know anything if it is bad or not. Right bundle branch lobe and left anterior fascicular block were demonstrated in more than half of the patients with acute total left main occlusion in a small series of patients. Here we see right bundle branch block, left anterior fascicular block, ST elevation in the anterior leads. Patient with left main occlusion. Right bundle branch with left posterior, you can see it from time to time, but again, we don't know if it adds any prognostic information. So in 2021, beginning of 2021, I wrote an editorial in Journal of Electrocardiology. Is right bundle branch the new left bundle branch lobe? Are we going to repeat the same mistakes? And this is a summary. Complete right bundle branch lobe is commonly found in the general healthy population, about 1.4% in men, 0.5% in women. Possible causes include trauma, infiltrative disease, degenerative disease of the conduction system, structural change, inflammation, and myocardial infarction. A large percentage of individuals with right bundle branch lobe have no clinical evidence of structural heart disease or coronary artery disease. And over the year, conflicting data has emerged concerning the long-term prognostic significance of RBBB in individuals without overt cardiac disease. It seems that after adjusting for age and other risk factors, isolated RBBB is not an independent predictor of adverse outcome. However, when it is combined with left anterior, left posterior hemiblock, maybe it is associated with increased mortality. So, potential explanation. Patients with right-banded branch lobe have more LAD disease, either as an infarct-related artery or concomitant pre-existing narrowing, and therefore they have bad prognosis. Patients with right-banded branch lobe have more diffuse pre-existing coronary artery disease. They could have larger infarct, leading to pressure or volume overload, stretching the right ventricle, causing transient right-banded branch lobe. Right-banded branch lobe can be a surrogate marker for older age, concomitant, non-ischemic myocardial or conductive system disease that overall associated with poor prognosis, and certain form of STEMI, anterior and inferolateral or posterior, what it's called before, are missed in patients with right-banded branch lobe, and I'll touch it. So, although we believe that right-banded branch lobe is not interfering with the diagnosis of STEMI or stress test, and therefore the current guidelines for the threshold of ST elevation are the same for patients with and without right-banded branch lobe. However, the diagnosis of inferolateral STEMI, ST depression in V1 to V4 is difficult because patients with right-banded branch lobe usually have ST depression in V1 to V4. How do we diagnose this, what was called posterior or inferolateral, in patients that come in? Here we see a patient with inferior ST elevation, reciprocal ST depression in 1 and AVL, and he has ST depression here. And we know that it is inferolateral STEMI equivalent with an indication for acute reperfusion therapy by the guidelines. Here we have kind of incomplete right-banded branch lobe and ST depression here, T-wave inversion without significant ST elevation. But now we have a patient with right-banded branch lobe with ST depression V2 to V5 with T-wave inversion. Is it inferolateral STEMI or is it secondary to the right-banded branch lobe? Can we reliably, if we have a previous ECG, say, oh, it was not there or not? We simply don't have any idea. So here we see a patient with incomplete right-banded branch lobe, LVH, and he has a little bit of ST depression here, and a little bit of ST segment elevation in the inferior lead. Can we call it? Can we activate the cath lab? This is a previous ECG of the patient showing that he did not have ST depression. So this just shows you the problem. Now we have right-banded branch lobe with minimal ST elevation or no ST depression in the anterior leads. If we say that many patients with right-banded branch lobe have baseline ST depression in V1 to V3, can it be that we should lower the threshold for ST elevation in the anterior leads for suspecting anterior STEMI? The guidelines don't touch it. The fourth universal definition of an eye doesn't touch it at all. We simply don't know. Another example of a patient with right-banded branch lobe and minimal ST elevation in the inferior leads. And what about incomplete right-banded branch lobe like here? Can we say that this is part of the right-banded branch lobe or is it part of inferolateral STEMI? Here we have ST segment elevation in the inferior leads that we know. Again, another patient with a little bit of ST elevation in V1 to V2. So the association of right-banded branch lobe, at least pre-existing, and acute myocardial infarction is most likely representative of more severe coronary artery disease pattern or more extensive comorbidities. On the other hand, development of new onset right-banded branch lobe in a patient with STEMI, especially anterior STEMI, could have different implications suggesting imminent risk. And the reported finding of lower survival, particularly in the early post-infarction phase, is an observation that merits further scrutiny. Currently, there is no sufficient data to support activation of primary PCI protocol for patients presenting with symptoms and RBBB without ST segment elevation, or as I said, ST depression in V1 to V4. However, if symptoms persist despite initial medical therapy, urgent angiography is warranted as the recommendation for all patients with ongoing symptoms or hemodynamic instability, irrespective of the ECG changes. Those are the non-STEMI guidelines. Thank you.
Thank you so much, Professor Yaki, for this very nice presentation about SCT segment elevation MI. And if you know the guideline recommending a primary PCI for any patient with STEMI as an urgent life-saving procedure, because you know the mortality in a STEMI patient very high. My question about the activation of the cath lab for primary PCI for patients who presented by typical pain and right bundle branch block with or without SCT segment elevation. So right bundle branch block with SCT segment elevation, it's easy task. So you have to activate the cath lab. But in patient with right bundle branch block with SCT segment depression from V1 to V3, this is a very difficult issue to solve. So what's your opinion if this patient presented to the ER? We can delay all patient, or we can go by all patient to the cath lab? I think we need more clarification for this group of patient because you know time is muscle, time is life, and if we leave the patient delay more than 3 hours without revascularization, we will lose the heart and we will end up by heart failure.
There are now discrepancy between the American ACC/AHA guidelines and the European guidelines. The European guidelines were published in 2018. The American in 2013 have not renewed yet. And this thing is, it's complicated. They don't say must. They say should be considered when persistent ischemic symptoms occur in the presence of right bundle branch block. Which means, if I understand it, they don't say you should activate this time. It's not primary PCI activation protocol. It is high-risk ACS protocol, and you have more time. Now, the question if echocardiography will help you. Is it reliable to see if you have a patient with right bundle branch block, ongoing symptoms, ST depression in V1 to V3, to rule out if he has inferolateral inferior wall motion abnormality? There is a recent paper that will come in JAHA about using the echo in patients presenting with left bundle branch block, and they couldn't see anything. But left bundle branch block has paradoxical septal motion. It makes things more complicated. Remember that we are not treating the ECG. We are interpreting the ECG with clinical assessment of the patient. And this is something completely different. And as I said, the problem is that if most patients with right bundle branch block have ST depression in V1 to V3, we don't know what to do if we don't see ST depression. Can it be anterior STEMI? I'm trying to find these databases. It's very difficult. Mainly because if STEMI-like anatomy is diagnosed, the hospital doesn't want to call it STEMI later for quality assurance purposes. So it's very difficult to find them. On the other hand, how to diagnose infralateral STEMI if you have ST depression in patients with right-banded branch lobe. So you need to be very careful and use, I think, the guidelines say, considered when persistent. So this is not a case when you should call the cath lab immediately. This is, you have to think, try to stabilize, maybe to do an echo, maybe to find a previous ECG and make a decision.
Thank you so much. Clear.